Hello and welcome to Acute Medicine 3 Answers. So just to remind you, there is a Q&A section on the UCL Moodle under Acute Medicine if you have any queries about the content or want to discuss any of the questions or answers. Good luck. So question 1 was a 73-year-old who has had a cardiac arrest and is in PEA, and we know that because the rhythm shown is asystolic, and the question is, how many chest compressions should you aim to do per minute? And so the answer is C. You should be aiming to do 100 to 120 chest compressions per minute for 2 minutes, and that is each and every cycle. Although it's important to say that if you start to get fatigued, then you're probably a lot more tired than what you think you are. So although the cycles are 2 minutes long, if you need to swap earlier, then you should, but should do it efficiently. So question 2 was about a patient admitted to acute medicine with decompensated alcoholic liver disease, and he asks you about liver transplantation, which is a relatively common question that we get asked when seeing these patients on the acute take. So the answer is B, that cardiomyopathy is a major determinant of alcohol. Let's talk about liver transplantation now. So alcohol abstinence is very important, but there is no fixed period of abstinence required. What is important, however, is that the patient is committed, has shown the capacity to abstain from alcohol, is engaged in a program, an alcohol detox and rehabilitation. Improvement in liver function tests is also usually seen within 3 months, so it may be that the patient doesn't require a transplant. You need to have a physiologically robust patient in order to perform a transplant. So physiology and biology is more important than a patient's chronological age. One of the answers, of course, was the fact that, or statement that most patients go on to start drinking again. Therefore, patient selection is key to successful transplantation. 1 year survival post liver transplant is around 90%, and so the answer is B, because you require adequate cardiac output. If the patient has a significant cardiomyopathy with poor ejection fraction, poor cardiac output, it's going to be very difficult to preserve and save a healthy liver. There is also an online tutorial on acute hepatology and liver failure on Moodle. So question 3 refers to a 28-year-old with weight loss with a full blood count results. So you'll notice that the patient is slightly anemic. The white cell count is normal. He's thrombocytopenic. He also has a lymphopenia. So this should be thinking to you about either a bone marrow failure or infection of some sort, or lymphoma are good examples. So when we look at question 3, the answer is D, HIV testing. So most of us will contract Epstein-Barr, varicella zoster, or cytomegalovirus at some point in our lives, and because we have robust immune systems and we're not immunosuppressed, we develop antibodies to all of these viruses, and therefore they are rarely of clinical significance except when we are immunosuppressed. So that's why A, B, and C are not particularly helpful, and they are likely to be IgG and IgM antibody positive, and therefore you're not likely to be of any use. Now, what they will be, however, is HIV positive potentially. The lymphopenia of unexplained cause, as well as thrombocytopenia, should prompt testing for HIV when the patient is clerked in. There is no suggestion here of treponema pallidum or syphilis. The VDRL, which you sometimes will see in medical notes and letters, stands for Venereal Diseases Research Laboratory. It's a little bit like referring to HIV as retroviral screening. It's trying to be polite in a kind of way and respect patient confidentiality. So question 4, the most important factor is the ability to communicate the decision by any means possible. It is important that the patient can retain information, but what we don't do is set a period of time, i.e. an hour, 6 weeks, 6 months. That's not really something that you can adequately assess when making that decision in real time. Certainly we don't prejudice in any way, the patient's education or intelligence. A Mini-Mentor score is not an assessment of capacity. It is an assessment of cognition, but not capacity. The two are different. And of course, the severity of any dementia also, again, is subjective rather than objective, and therefore cannot be measured in the assessment of capacity, although it would be a factor in affecting someone's capacity. So when we assess capacity, you must check that the person has mental capacity to make a decision at the time it needs to be made. And there are 4 key aspects. Understand the information that they need, for example, what the consequences will be. So for example, if you don't have this amputation, you're likely to get gangrene and die of sepsis, for example. Remember the information for long enough to make the decision that you can have a conversation which is complete, and when you summarize, for example, the patient is aware of the information that you have given to them. Weigh up the options and make a choice. Now, what's important here is that they are able to process the information to weigh up the options and make a choice. Now, patients are perfectly entitled to make what we would consider an irrational response to a question. It might not be something that we agree with, or as medics we are suggesting that the patient have. Ultimately, if the patient has capacity, they have an ultimate right to refuse, an ultimate right to make an irrational decision. It's also important that we do everything that we can to communicate their decision in any way and facilitate this. So it might be, and sometimes is done, blink once for yes, twice for no, although of course that has to be carefully done, using pointer boards and things like that you can use to communicate your decision. There's a relatively good short piece on a website, www.gov.uk/make decisions for someone assessing mental capacity, and I suggest that you are aware of at least the 4 parts of assessing capacity. Question 5. So on the next slide there is a chest x-ray. Review the chest x-ray. What is the radiological diagnosis? So you can see what are described as cannonball infiltrates. And so the answer is E, advanced metastatic cancer. Multiple lung abscesses are likely to present like this. They'll often have cavitating lesions. This is very different to an advanced primary lung cancer. You would see often a single metastasis rather than lots of little ones like you see. You could consider miliary TB, but these are more solid lesions that are seen. Miliary TB has a more sort of speckled appearance. So the answer is E. So when we see a chest x-ray like this, I've listed up there some of the cancers that metastasize to the lung, and they include bladder, breast, colon, renal, prostate and germ cell tumours, such as testicular and ovarian cancer. And therefore it's always important, if you see a young age patient who has concern about his testicles, to get a chest x-ray as well to see if there is metastasis and also sarcoma. So question 6, which of the following is not part of the National Early Warning Score? And that's A, Glasgow Coma Score. There is the AVPU scale, but not the Glasgow Coma Score. They are different. So remember that on the new score you have alert, confused, voice, pain and unconsciousness responsive levels. The other 4, B, C, D and E, form part of the National Early Warning Score. So question 7 is about a woman who presents to the emergency room who has a left lower lobe pneumonia. Curb score is 0. She has no allergies, so the appropriate antibiotic to give is A, oral amoxicillin 500 milligrams 3 times a day. B, oral doxycycline is primarily used for exacerbations of COPD. C, this patient is quite well, so that would rule out C, D and E as there are no contraindications to no need rather to give any intravenous therapy as the patient is relatively well. So if you needed to, you can double the amoxicillin to 1 gram 3 times a day. Answer D, intravenous co-amoxiclav is used for more severe community-acquired pneumonia, so CURB score 3 and above. The correct dose is 1.2 grams 4 times a day. Question E is wrong on both counts. A, because the co-amoxiclav is not indicated, and also 4.5 grams is the dose of tazocin, not co-amoxiclav. So question 8 is about medication related diarrhea, a relatively common presentation, and again, so it's important that when you clerk your patients in that you take a good and detailed drug history, particularly asking how long they've been on these medications. So the answer is B, co-caraldopa. So what I suggest again is, even if you don't know the pharmacology or side effects of these drugs very well, again, this is about thinking about using your BNF or accessing BNF online. Hopefully when you look to the patient, you should have a thought that they may have Parkinson's disease and therefore require co-caraldopa. Common side effects of co-caraldopa include dry mouth, bitter taste, nausea, vomiting, abdominal discomfort, flatulence, diarrhea, and ulcers. You may be aware that omeprazole and PPIs do cause diarrhea, although it's predominantly water diarrhea. This patient was only having her bowels open 4 times a day. Bisoprolol causes dizziness, fatigue, wheezing, and mild but transient GI upset. Statins primarily cause deranged liver function tests and inflammation of the liver, and diarrhea and GI upset otherwise is very rare in statins. Paracetamol again can sometimes cause diarrhea, but that's a very rare side effect. So question 9, a patient is referred by his GP with a rash, which is shown on the next slide. He's recently had a cough, which should suggest you the patient may have had some antibiotics. He is systemically well, and again, this is important in ruling out likely autoimmune diseases or other serious illness. So what is the single most likely diagnosis? There you should see the rash here of a drug eruption. And so the answer is D, drug eruption. I've put up here a typical rash seen in autoimmune disease. You can see it's a salmony pink rash here, can be widespread. You may also want to look at the sort of the knees, under the armpits and so on, back. You want to have a good examination of the patient, including the scalp as well, when you are assessing someone's rash. So you can see a salmon pink rash here. This here is the typical rash of meningococcus. You can see here that you press in the glass test to see, and you can also see that it's a non-blanching rash. This is a rash associated with syphilis. A good place to look for syphilitic rashes is the palms of the feet and hands. So question 10, on the following slide, there is a chest x-ray in both PA and lateral view. I asked you to have a look at the chest x-ray and decide on the diagnosis. So if you have a look here at the PA and lateral views, you can see the 2 arrows which are pointing to, on the PA film, a air fluid level, and similarly to on the lateral view. So the answer is E, hiatus hernia. There are no, so perforated stomach, you'd see free air under the diaphragm. This air isn't free, it is enclosed in the fundus of the stomach. There's no consolidation in the lung and no sign of solitary malignancy. Therefore, the answer is E. So question 11, an 85-year-old woman is admitted to acute medicine with confusion. A chest x-ray is performed. Consultant says she needs a specialist review. Which is the single most appropriate specialty? So if you have a look at this x-ray in the top left hand corner, you may have noted the shoulders even allowing for rotation. There is considerable disruption and distance of the AC joint, so this woman has had a fall, probably due to her confusion, and has got an acromioclavicular injury, and so therefore the answer is A. She should have an orthopedic review to see if she needs an MRI or further imaging of her shoulder, and probably a collar and cuff and physio. There's nothing else on the x-ray to suggest that she needs to see respiratory, neurology, cardiology or infectious diseases. So question 12 is all about the management of a hyperacute stroke. So the patient is 70 and she's immediately brought to the emergency department, and when dealing with acute stroke, timing is of course critical. She's had a plain CT head, which is normal. Now what this is telling you is that it is not, or very unlikely to be, a hemorrhagic stroke. But it won't necessarily show the actual area of infarction, as it's too soon. So of course we've been rung for advice as the acute medical team. So the answer is A. You want to refer this patient to the hyperacute stroke unit for consideration of thrombolysis. Now you might administer aspirin if the patient was out of the 4-hour window for thrombolysis. Again, this patient would have an urgent MRI head, but it's not going to change your immediate management, but it will characterize the stroke better. There is no need to repeat the CT head with contrast. You have already excluded intracranial hemorrhage. Acute intracranial hemorrhage will be seen by the fresh blood on the CT, therefore D is not necessary. And E, low molecular weight heparin, you may want to do that in terms of prophylaxis, but certainly not yet. This patient needs treating for thrombolysis, with thrombolysis for an acute infarction. You should also have spotted that this is likely an infarction given the hemiparesis. So I've put up here some suggested reading for you. This is an update review article about thrombolysis in acute stroke. The patient meets the key criteria for thrombolysis, therefore the answer is A. So the indications for thrombolysis with the drug autoclaves includes clinical diagnosis of ischemic injury, which this lady has. She had a dense hemiparesis. Patient's age less than 80 and greater than 18 years old. Treatment can be commenced within 4.5 hours of onset of symptoms, and we know from the history that she was immediately called. Her husband immediately called the ambulance and brought her into the emergency room, and we've excluded hemorrhagic stroke on CT. There's no obvious evidence that she has any contraindications, including things like, but not limited to, active internal bleeding, aortic dissection, previous intracranial hemorrhage, seizures, and another list of things which you can reveal on the website. So which of the following is not considered a reversible cause in cardiac arrest? The answer is C, trauma. So this is about knowing your 4 H's and 4 T's, which are discussed on the Acute Medicine PFP resource talk that is online. So the answer is C. The other 4 are correct. So question 14, this is a man who has palpitations which are getting worse. Then I presented to you the ECG and asked you to have a look at it. On the ECG, you should notice that there are absent P waves and irregular QRS complexes. Therefore, this should make you think that this patient has atrial fibrillation. And indeed, the answer is B, atrial fibrillation. This is a sinus arrhythmia ECG here. The reason it's sinus arrhythmia is that the patient still has P waves followed by a QRS complex and a T wave. So when thinking about blocks and arrhythmias, this is a 1-to-1-to-1 ratio. So this is sinus rhythm. This is just a fairly common phenomenon. Patients will often just see or feel palpitations with ectopics or sinus arrhythmia. The ECG here is of Wolff-Parkinson White. Couple of things to look at when you're looking for Wolff-Parkinson White include a PR interval of less than 120, delta waves which are slurring or a slow rise of the initial portion of the QRS complex, and a QRS prolongation of greater than 110 milliseconds. Question 15, the same patient on examination has a heart rate of 120, the blood pressure is 160/90, and there are no audible murmurs. Thyroid function tests are normal. The acute medicine registrar asks you to suggest a management plan, and the question was, which is the single most appropriate management plan? So the answer to question 15 is to commence oral bisoprolol, apixaban, and discharge the patient back to the GP. So the answer is A. This patient is otherwise hemodynamically stable. In non-valvular AF, using a DOAC is much more appropriate than warfarin. This patient is well and they can be discharged back to their GP. There's no indication for warfarin or admission. There's no indication for DC cardioversion, although you may consider it electively. But again, it's important to remember this patient has had probable AF for some months now, so doing a DC cardioversion without anticoagulating them potentially will give them a risk of stroke. And remember to use the CHADS-2 VASC2 score to assess that risk. There's no indication for oral digoxin at this time. It's potentially going to be your second or third line agent. Aspirin also is not enough for anticoagulation therapy, only if the patient has a real risk. If they go on to anticoagulation, should warfarin be considered. Again, there's no indication at this stage for oral amiodarone and warfarin. Amiodarone is likely to cause deranged thyroid function tests. This patient has normal TFT, so therefore we don't want to cause harm by giving the patient oral amiodarone. So question 16, which of the following is not an adverse feature when managing a tachy or bradycardia? And the answer is A, hypoxia. B, C, D, and E are all features which are on the tachyarrhythmias and bradycardia algorithms from the Resus Council website. So question 17, this young man, again, which is an important epidemiological feature, he reports sharp and central pain. What should stick out to you is that this pain is relieved by sitting forward, and in combination with an ECG that shows widespread ST elevation, you should be thinking that this patient has pericarditis. So the single most initial appropriate treatment is non-steroidal anti-inflammatory drugs. A widespread or ST elevation myocardial infarct is very unlikely in someone who is 25, so therefore there's no indication for A or B. You can use aspirin and prednisolone in pericarditis, but it's much more beneficial to the patient to use high-dose non-steroidal anti-inflammatory drugs, as this will hopefully reduce the inflammation of the pericardium and give pain relief. I've shown for you here on this slide a typical ECG that you see in pericarditis. You can see that there's widespread ST elevation throughout. Question 18. So again, this is about knowing some of the typical phenotypes that you see with various diseases. This is a 40-year-old. It's a female. She's 110 kilos. So you should be thinking about biliary colic and gallstones. This is further evidenced by the pain radiating to the back and scapula, and that she is nauseous and vomiting. So dissecting aortic aneurysm can cause pain in the scapula. It's often a tearing pain, and she'd be a lot more critically unwell. And also the pain is in the right upper quadrant and epigastrium. Gastroesophageal reflux is possible, although the history is much more in keeping with biliary colic. Again, there's no evidence to suggest myocardial infarction or hiatus hernia. So question 19, an 85-year-old woman is admitted under acute medicine after multiple falls at home. Her ECG is normal. Her medications include aspirin, bisoprolol, furosemide and simvastatin. She has mild aortic stenosis, and again this should be a flag to you about her being on beta blockers, for example. Her hemoglobin is 110. There are no other findings on examination, so what should you be doing next? And the answer is D, lying and standing blood pressure. She would potentially need an echocardiogram, but there's no need for it to be urgent. It depends on when she had her last echocardiogram. If it was in the last 6 months to a year, doing another one is unlikely to be helpful, but we generally surveil these patients once a year in an outpatient setting. Her initial ECG is normal, and unless this patient has had palpitations, the yield of 24-hour tapes is very low, unless you think that within that 24-hour period you are going to record and therefore diagnose an arrhythmia. There is no indication for CT head at this time, unless she had evidence of head injury, and it would be useful to do a CT head. She is likely to have a CT head, but this lady is also on furosemide, having regular falls, and an older, frailer patient. Therefore, the next step should be to do a lying and standing blood pressure. It is likely that she'll have a CT head, but D should be done first. You can consider tilt table testing. I'll talk about the indications for that shortly. So just as a recap of the indications for a CT head: acute stroke, acute suspected subarachnoid hemorrhage, suspected space occupying lesions, suspected intracranial infection, mental status change, head injury, orbital cellulitis, suspected skull or facial fractures, and suspected congenital anomalies. So being an elderly faller isn't necessarily in itself an indication for a CT head. I don't think it's unreasonable to say that a lot of my colleagues in emergency medicine would CT scan the patients if there's any concern, or the history isn't particularly clear, and I'd agree with that. None of that is evidenced in the question, so the answer is to check a lying standing blood pressure, which is probably being caused by the diuretics that she is on top of the bisoprolol. The way we would manage this is to potentially stop or reduce her furosemide and or her bisoprolol. Indications for tilt table testing include hypotension, which is unexplained, tachycardia, orthostatic palpitations, dizziness, lightheadedness, and frequent unexplained falls, or history of episodes of fainting or loss of consciousness, which cannot be explained otherwise. And so the final question is about acute medical emergency. This is a patient who's had myocardial infarction, so you should be thinking about arrhythmias, pulmonary edema, dissection, and so on. She's on standard medications for an ACS. One of the clues here also is that the timing of the emergency is 4 a.m. so this should be making you think about pulmonary edema secondary to the myocardial infarction. When you arrive, the patient's on high flow oxygen. Again, the sats are only 90, so there's a big gradient there, so again that should make you worry that there is a primary A or B problem. Now we know it can't be an A problem because her airway is patent. She also has a respiratory rate of 40 with widespread crackles, so again that's very much keeping with pulmonary edema. Her heart rate is 130, but it's regular, so that effectively rules out an arrhythmic cause of her patient's condition. So you do an arterial blood gas, which shows a type 1 respiratory failure. So you should be thinking about things like hospital-acquired pneumonia, CCF, pulmonary embolism, pneumothorax, and so on. The answer is B, continuous positive airway pressure. So let's talk about the others. Dobutamine is an inotropic agent which would be used if the patient had signs of cardiogenic shock. She has a normal blood pressure, therefore dobutamine is not indicated at this time. Repeat troponin test. Well, we already know that she's had a myocardial infarction and she's developed pulmonary edema, so a change in troponin is not really going to change how we manage her. If there were significant ECG changes, then again we may consider another trip to the cath lab. However, this patient is profoundly hypoxic and has signs of pulmonary edema, and that needs treating. A repeat troponin is not going to be particularly useful in deciding what we do next. Similarly to a BNP test, which is used for heart failure, she has clinical heart failure, so you know that the BNP test will be elevated anyway, so it's of questionable value. You could consider a nasopharyngeal airway in the initial stages of patients with pulmonary edema as well as frusemide. The role of the nasopharyngeal airway here would be to facilitate chest suction, so you can put a nasopharyngeal airway in and a fine bore suction catheter which will suck down into the chest with a bit of chest physio to get up some of the edema, and that can make the patient feel very better. However, her respiratory rate is very high, she's clearly hypoxic, she's very close to exhaustion. Therefore, she needs an application of positive airway pressure, and that will help reoxygenate her lungs and keep her alveolar open, so that the edema can essentially be pushed back out of the lungs. And so this can be done on CCU or a critical care unit. So thank you very much. I hope you did well on the quiz. Remember that there is a Q&A section on Acute Medicine Moodle if you have any queries about anything that I've told you. There will be further tutorials up on Moodle, and I wish you all the best.